Thank you for that warm introduction. Uh, it's a pleasure to be here. I just want to make sure everyone can hear me.
We can hear you.
Okay, it's a pleasure to be here. I am excited about talking with you because you are the future of psychiatry, the future of APA, and the future of psychiatry. And I know I heard that when I was a medical student and a resident, but it really resonates after you've moved on and you're watching people grow and you grow and you can contribute and pay back. So welcome to the APA, and on behalf of the APA, we are grateful that you're involved in Psych Sign and have an interest in the profession, because we need to expand and grow the number of psychiatrists in the profession and improve the quality of care throughout the 21st century so that we can provide cutting edge medicine, medical care, research, and advocacy for our patients. So today, I'm going to talk a little bit about structural racism, structural competence in medicine. And how did I get into this topic? Well, first of all, I'm African American, so I grew up Black, and I know about some of these aspects because I've experienced some personal experiences, etc. For example, actually, two Martin Luther King weekends ago, in 2018, I was going met with a couple of friends from Kentucky, and they're both white females. They're tall, older, and we went to an art museum to pick up a piece of artwork that I had purchased in an art show. And we were all going in. I had my paperwork. They both walked in, and I got stopped at the door. And I was asked, may we help you? And I said, well, I'm here to pick up artwork. And they asked me, for which artist? I said, for myself. Uh, I purchased artwork. Do you have any proof that you purchased it? Sure. And I gave it to them and I said, here, while you're packaging that, I want to look around and just look at the art a little bit more. Well, when we left there, my friends were fuming and they said, why did you let that go? They asked me, I said, let what go? They stopped you at the door. I said, they're supposed to stop me. There are thousands, if not hundreds of thousands of dollars worth of artwork in this room, and they don't want me to walk out. They said, but you don't understand. We didn't purchase any art. We were dressed more casually than you were, and we walked in without any question asked. And it put a downer on the day. And I said, what, can we talk about something more positive? And they said, no, because you're not owning up to the fact that you were discriminated against. I said, no, actually, you were subjected to privilege. I wasn't discriminated against. I expected them. The paperwork said, produce this. And they said, well, but aren't you upset that we got treated differently than you? And I said, no, because I am not here to debate with the people. I just wanted my artwork and I got it. If I spend time ruminating on this process, then that's going to be unhealthy for me. In other words, I experience these types of things, perhaps obviously more than you do, but I found a way to work through it, not to give them the power, but to make it work for me. So I was thrilled. I had my artwork. That was my goal. I will never see those people again, likely in my life. And I got what I wanted. And that compelled them to learn more about things. And they started taking courses in cultural psychiatry, et cetera. They began to volunteer with kids in a CASA program who were in foster care and such, and try to understand the dynamics. And they also developed a greater interest in mental health. They are education, and one's a nurse and one's an education lawyer. So it opened their eyes to something that I was familiar with, but it also opened my eyes because they're right. 30 years ago, I may have been angry about that, but I let it go. And that's a sign of health for me because I can't change that situation in that particular situation. So I find another way to do it and put my energies into things like the APA task force, Presidential Task Force on Structural Racism. So we're going to talk today about addressing structural competence in medicine. If now, not now, then when? Our objectives are to explain how structural competence can improve the quality of medical practice, describe how structural racism contributes to health disparities, and understand what the APA is doing about structural racism. And I have no disclosures. And I like to begin talks, and even before I meet with the task force, structural racism task force, to put things in perspective. And this a quote from late Eleanor Roosevelt, who's first lady of our country, really resonates with me. Great minds discuss ideas, average minds discuss events, and small minds discuss people. And it helps me remind me what my priorities are. So in that situation in the museum, I could have been the small mind and discussed people, or the event. I wanted the idea of concept of my artwork, which was I was looking forward for several months until I had to wait until the art show ended. Okay, so let's talk about race versus racism. Race is a social construct or creation of a social reality based on physical characteristics such as skin color and hair texture. In other words, nobody's born with a stamp that says you're this race. This is something that man created for his own designs to distinguish people and have a hierarchy of people, a caste of types, of sorts, if you will. And racism is a system of structuring opportunity and assigning value based on social interpretation of how one looks. So race is very important to racism, and people use race as a justification of it, but it's a social construct. It is not a medical or genetic property. If you look at Henry Louis Gates Jr. when he does the test where he on PBS, where he goes and looks at people's ancestors, I remember watching one episode and there were only two pure white people on the show. It was Meryl Streep and Stephen Colbert. And even they were shocked because we are genetically homogeneous people. Systemic racism, on the other hand, encompasses the systems that uphold and adapt racism to evolutionary changes in society. In other words, systemic racism keeps changing to keep that system in control. So first we started with, for example, slavery, and then we moved to Jim Crow, and then we have some other things with litigation and criminalization, or the school to prison pipeline for African Americans, particularly African American males. Apartheid is was another example of systemic racism, and of course, caste systems. Without systemic racism, you cannot have structural racism. So systemic racism is the bedrock on which structural racism is predicated. Now, when I talk about systemic racism and structural racism, I'd like to talk about another person that I admired, Barbara Jordan, who was the first Black senator, House of Representatives member from the state of Texas since Reconstruction. And she was the junior House member who was selected to serve on the Watergate panel when they were looking at President Nixon to impeach him for the Watergate scandals. And she's going to tell us a little bit about we the people and the Constitution, so we can understand where she's coming from this and get a historical perspective of this. Now, this was in July 1974.
I don't think we can hear it if it's playing, Dr. Wills.
Excuse me?
We can't hear the sound on the...
Okay, that's unusual. Hold on, I pulled out my headphone. Let's try it again. Can you hear it now?
No.
Okay, well then we'll stop it. I don't know what's going on there. I did remove my headphone because I wanted to make sure you can hear. Back at the Constitution, she realizes that the preamble is we the people, and that she was not included in we the people. And she thought that Alexander Hamilton and colleagues made a mistake about that. But we know from history that this was intentional. Women were not included in we the people, and Blacks were not included in the we the people. And there was discussion about this, and this was the decision. The Constitution was for white property owners. So, but she says that while it hurt her feelings, she also knows that in this great country, by amendment, interpretation, and court decision, she became part of the we the people. And then she says her faith in the Constitution is whole, it's total, it is complete, and she's not going to let anybody denigrate or step on it because it's dear to her. So let's move on and look at a little bit more of the aspects of the Constitution and amendments to the Constitution. Let's take voting rights, for example. Now, those of us who studied American history, it's been a while for me, but remember that the Civil War was from 1861 to 1865. That ended slavery. Of course, we've heard more about Juneteenth, where even though slavery had ended, not everyone knew it. And actually, it was really impressive that New York State made it Juneteenth a holiday for government workers. So this is something that's changed in this year that was monumental because a lot of us have known about it. Not everyone's known about it, but by the end of this summer, most people knew about it. Okay, so Civil War ended slavery, but it wasn't legislated. So they had to come up with these Civil War amendments to the Constitution. The 13th Amendment was in 1865, and that abolished slavery. The 14th Amendment made slaves citizens, and the 15th Amendment, which is also known as the Civil Rights Enforcement or KKK Act, gave teeth to the 14th Amendment. It outlawed voting discrimination, lynching, poll tax, but that was followed by lynching, poll taxes, and literacy tests. So those were outlawed, but they still occurred. And we also know about Jim Crow. That went on and throughout the mid 50s and part of the 60s. Okay, so let's move to 1920 or thereabouts and women's suffrage. As we know, last year was the centennial of women's suffrage movement. Now, what was interesting about that was that you had Black women and white women having different perspectives of it. And basically, many of the stories about women's suffrage do not include Black women, but people like Sojourner Truth, Kenny Staley, etc., were involved in this process. So one of the things that happened there was Black women and white women had a differ in opinion. White women said, let's just focus on women's suffrage, get the right to vote, and everything else will fall in place. And Black women said, you've got to be kidding. We need all of our rights, not just voting rights. I mean, if we do that, then you'll be able to vote, but we'll still be second-class citizens. And eventually, Frederick Douglass was involved in this, and he decided to side with the white women. Why? Because he thought that they had a better chance of winning rather than going for more than one item. And so the 19th Amendment ratified the vote, but Black women as a class were still not able to vote. One of the things we know about Condoleezza Rice, who was the former Secretary of State under the second George W. Bush, said that in her memoir, she said that she will forever be a Republican. And she explained why. Her mother was lighter complected, her dad was darker complected, and a big, burly kind of a husky guy. Mom, who played piano, was graceful, etc., was able to read a test and get her right to vote with the Democrats. Dad went to do the same thing, and he was told, we see you can read, but what we really want you to do to vote is to tell us how many jelly beans are in this jar. So he was not able to register to vote as a Democrat, but he had a number of Republican friends, and they said, "Come on, we'll help you get registered," and he did. And that when she heard that story, she said she would be a loyal Republican for the rest of her life. So let's move on to the 1960s. We heard a lot this summer about Representative John Lewis, who's legendary in the civil rights movement. He was part of the Bloody Sunday over the Montgomery Bridge. There were 3 of those where they let dogs out to bite and attack the protesters. He was also a leader in the Student Nonviolent Coordinating Committee. And he was one of, I believe, 6 people who coordinated the March on Washington, one of the 3 key in 1963. He was alive when the U.S. Voting Act said that Blacks had the right to vote and you could not discriminate against them. And that, again, just like the Civil War, not the Voting Rights Act had 5 additional amendments to make this thing work and be fundamentally fair for all people. And members of the Department of Justice had said that this was the most far-reaching and powerful legislation that that we've ever had in this country. Um, Now we know that. Oh, one other thing about John Lewis from Georgia, he became a U.S. Representative, and he had served 17 terms before he passed away. That means the folks really believed in him, but in APA we do have term limits to prevent this from happening. In terms of where this went, there were many efforts to fight against this, but in 2013, a case went before the Supreme Court. Shelby v. Holder determined that there was enough progress in terms of voting rights so the states could take over power of drawing voting lines and divisions. And that was part of what contributed to the problems in 2013 with disenfranchising people. And of course, we know what happened in 2020. So with that said, we have a long way to go. It was unfortunate for, after risking his life so many times for the Voting Act to be ratified, that Representative Lewis lived 4 years after that was overturned. And so still have a long way to go. We have to be careful about the nuances there. So let's move on to Black Lives Matter. This has caused a lot of controversy and problems. Blue Lives Matter, nurses matter, women matter, etc. But what this is truly saying is you all matter. And by the way, Blacks matter too. We're not an afterthought. We should not be an afterthought. Our safety, our rights, our privacy, our desire to be treated with dignity should be right up there with yours. So it's not discounting anybody. It's saying, give us a fair shake and put us on the same level playing field with you. So let's talk a little bit about racism. Types of racism. Systemic racism, as we mentioned, is adaptive and evolving, and it's the bedrock on which other types of racism are predicated. Internalized racism is people based on what they've learned over time, and it becomes either subconscious or maybe in some cases unconscious. People buy into stereotypes, and that can go either way. It can go based on your bias against someone who's different than you, but we also see Blacks having internalized racism based on their upbringing, their experiences against Blacks. For example, I had a colleague who came to me and said, as an intern, what should I do? I have a Black patient who says that she only wants a white therapist. And she explored that with the patient, and the patient explained that everything that bad that happened to her in her life had to do with Black people doing it to her and being involved, and she just wanted a chance to have a different experience. The reality that white people could do that to her too, or other people could do that to her too, was not a consideration for her. So she went to another provider, and I hope she did well. But that again, it's not specific to whites versus Blacks, etc. You buy into stereotypes based on what we're exposed to. As a matter of fact, there's the Harvard implicit bias test. We did it in our institution, and two things came across, interesting things. One resident who transferred from an inner city medical school, did most of his rotations in an inner city environment and switched to a suburban environment, said that he was amazed how his biases had changed on the test, the same one he had taken a few years ago, over time. And then there was another woman who said, my family is totally military, but the test said I'm biased against, and I think Blacks when it comes to guns. And then we talked about how media influences how we perceive things and how we internalize things. So even though she would have attributed her understanding of guns to white, she sees it, even if she's not paying attention to it, it's pervasive. So she, without realizing it, developed these biases. And then there's external racism. That's usually between individuals. And that's very different from structural racism, which is also known as institutional racism. And that classification of institutional racism is based on an intent. And we'll get into the definition of it actually. And I think the slides flipped around. But There's direct institutional or structural racism that is intentional, and that's often legislative. You cannot go to hospital X if you don't live in Y catchment area. If you live here, you can't go to this school. Um, if you are certain income or certain circumstances, you get X, Y, and Z. But it also can be direct, like mortgage discrimination or redlining and zoning laws to decide what you have access to, where one school system has more resources and another one doesn't, or which healthcare facility you go to, or recreation facilities. And of course, we've talked something about a little bit about public safety. Where you have the school to prison uh, pipeline. And one of the things about that is more resources are put into arresting and confining people rather than rehabilitation. Then we have indirect or unintentional institutional racism. And that's where we maintain structures, programs, policies, and practices that were established. So the person who is implementing them and reinforcing them and maintaining them was not responsible for establishing them, but by perpetuating them, they are involved in an act of racism. And this is the most subtle one that we're dealing with most because most people don't want to believe that they're engaging in racist activities. But some of it is ingrained, some of it's built in. For example, if you tell your best friend from your fraternity or from your medical school class about an opportunity and they get to it beforehand, or you tell them how to prepare for that, you're giving them a competitive advantage over the person who doesn't. And there have been studies about minorities, especially women, who have been harassed or sexually, physically harassed, where they don't move ahead in part because they don't take part of the networking opportunities because they feel either imposter syndrome or they've been so traumatized they're trying to engage in self-protective activities to protect themselves, but it's to their professional detriment. So, addressing these types of racism may require activism, as we saw this summer, litigation, and other interventions because they're ingrained and because people resist it. Again, nobody wants to believe they're engaging in racist activity, and nobody's saying that some of these things are intentional, but they're just there. Now, structural racism is the same as institutional racism, which was coined by two psychologists and sociologists in 1967. It's a combination of policies, public policies, institutional practices, social forces, ideologies, and processes that generate and perpetuate inequities among races. So you have them and us. And that's the official definition that the task force is using. And again, it's structural racism also is the bedrock of psychosocial inequality among races, and it results in cumulative and chronic adverse outcomes for the non-dominant group. And this is extremely important because when you have those adverse outcomes, perpetually adverse childhood experiences and moves into adulthood, etc., it can affect the mental and physical health of our patients and their families. And that's where we come in. So we're seeing the outcomes of structural racism, but we may not be trained to look at that and appreciate it. Some hospitals do have orientation now where they orient you and educate you about structural racism so you can better understand the populations that you're working with. And they, in some places, you can't touch a patient until you complete that training, just like electronic health record and registration. Now, let's move to another topic. We're just going to touch on this intersectionality, the complex and cumulative way in which the effects of multiple forms of discrimination, such as racism, sexism, and classism, combine, overlap, or intersect, especially in the experiences of marginalized individual groups. So, say you're a gay Black male. Well, the combination of how you're treated as a Black male and how you're treating as non-binary, that cumulative effect affects you and your opportunities and the stressors you experience in terms of your experiences, and that affects how you function, how you view the world, your relationships, etc. So, to better understand this unconscious bias or the unintentional structural racism, the what I want to talk about is Peggy McIntosh's concept of white privilege. And she wrote an article, White Privilege Unpacking the Invisible Knapsack. Now, this came from a 1969 article where she was a women's studies professor, I believe at Wellesley at the time. And she wrote an article about the invisible backpack to help people understand male privilege. And then, excuse me, she later extended that to white privilege. And what she said was white privilege is like an invisible weightless knapsack of special provisions, maps, passports, code books, visas, clothes, tools, and blank checks. And basically, the knapsack contains, or you can think of it like a utility belt, a lot of unearned assets that you have that other people don't have, and you count on cashing in every day, but you're conditioned not to realize it's there. For example, I had a colleague who said he works at an Ivy League school, he trained there, and he's black, and he said he had a colleague from Kentucky who says that there should be no racism because he worked hard to overcome obstacles so that he could get there too. So why is there preferential treatment, etc.? And what his friend, he used this metaphor, the black doctor used this metaphor to explain it to his colleague, and he said, "Now that I've said that and you understand that, let me tell you that there are places on this campus that I can't go, but you will go, and no questions will be asked." And that is the internal bias. So no matter how many credentials one person has, they may not be able to partake of this. Now, do blacks and other minorities get a knapsack? No, let's say they get a paper bag, and some paper bags are bigger than others, or some have holes in them, grease spots, etc. So it's not as sturdy, and they may have some resources, but they're not starting with that competitive advantage. On the other hand, the backpack knapsack also varies for whites. For example, if you're Jewish and you live in New York City, you may have a backpack full of resources. However, if you move to South Dakota and that same person, that backpack is going to have fewer resources in it by nature of it, but it's still a backpack. And here's an example of some of the information privilege, and this is a great example. My high school had lots of technology. My school prepared me for college level research. I'm able to purchase textbooks. My university has a special collections library. My professors encourage academic freedom. So these types of things that we take for granted are in that backpack, that knapsack, whereas someone with a paper bag may have a couple, or they may have a few, or they may acquire them on the way, but they didn't start with that at birth. The potential for these advantages. And again, each person's backpack is different. Excuse me. Okay, so let's look at systemic and implicit bias. It affects morbidity and mortality. And basically, those biases are introduced to create that caste system to disenfranchise a class of individuals. And the ones that I put in yellow are the ones that we most care about as healthcare providers, although the other ones are extremely important too: zoning laws, where you live, etc. Financial or mortgage discrimination, infrastructure, depending on which resources you have, etc. But how illnesses are defined, how clinical trials are conducted, nutritional services and resources, and healthcare are extremely important. Now, historically, in terms of structural racism, we were taught that what happens in terms of morbidity and mortality is attributed to someone's race or ethnicity. But we know over time, when we really look at this, that it's the institutional or structural racism that's contributing substantially to the problem. For example, in about April or May, State Senator Stephen Huffman, who is from Dayton, Ohio, is a physician, and he said publicly that the reason that colored people were getting COVID so much more than whites is that they had poor hand washing practices. So the fact that he said colored clearly indicates that he is way behind the times. But what happened as a result is the hospital system fired him. But at last check, he is still a state senator. So that tells you something. Now, why is it important? The to become culturally competent. And there's been a movement in medicine to move toward this because it can help change treatment outcomes, because you start to understand the downstream effects of those policies, practices, and programs, and how they affect people biologically, economically, culturally, and racially. You can reduce internal and external stigma and bias, and you can support culturally competent care, because systemic bias contributes to health and wealth disparities. But it also makes it more efficacious or more advantageous, or to facilitate evidence-based care, because you're doing more diverse research, your populations change. For example, federal government, when they do offer a lot of these grants, they want to know how you're going to involve stakeholders and how you're going to have diversity introduced into that. So diversity, James Jackson, the late James Jackson, was a very important figure. He was a social psychologist at the University of Michigan, and in 1980, he completed the National Survey of Black Americans, and he took a lot of risk. And in retrospect, he said that was really crazy and dangerous. He had people going into, you just like the census, going to door to door, some of the worst neighborhoods, some of the best neighborhoods, and all around. He got this data. What that data showed was groundbreaking. It showed that Black people are complex, and not all Black people are alike. So that was the first time we had some data to say that we cannot lump all Black people in one category. So while people knew that, many people knew that, this was the evidence that they needed on which to predicate all of this. And he started a program at University of Michigan to develop this further. So what about medicine? Well, let's look at systemic and implicit bias in colorectal cancer diagnosis and mortality. You see three people there, three Black men who were prominent. Darryl Strawberry, who played for the Nets and the Yankees and was part of four winning World Series teams, was diagnosed with colorectal cancer at age 36. Ibram Kendi, who wrote How to Be an Anti-Racist, was diagnosed with stage 4 colon cancer at age 39. And we know about the late Chadwick Boseman. So what do we know about colon cancer? The steepest increases are happening in the 21st century in 20 to 39-year-olds, more in women and more in Blacks versus whites. Blacks are 20% more likely to be diagnosed and 40 to 50% more likely to die of colorectal cancer than are whites. Yet, these three men had the diagnosis made before age 40, and colonoscopies are required at the earliest is 45 years old, when your insurance provider will cover them. So, is this overlooked? Is it based on stigma that people don't want to have rectal exams, etc., or colonoscopies, or don't want to talk about this? Is it bias? It's probably some of all of those. But one thing we know is that if you're going to get those numbers down, 20% more likely to be diagnosed, and particularly up to 50% more likely to die, we're going to have to do something to change those parameters to get those assessments earlier. And there are a few more tests coming out that you're probably seeing at medical school that weren't out beforehand. But one of the things I asked patients after Chadwick Boseman died, for about 2 weeks after, I asked every patient, when you had your physical, did you have some type of rectal exam or some type of testing? Anybody over 35, I asked, and none of the people under 45 did. And none of the two people above 45 did, beyond their first colonoscopy. And some hadn't even had that, and they weren't even told about it. So we as physicians have got to do better. We have to destigmatize this, educate people, and follow through, because all of the people I was asking had insurance, which is how they got to see me, but they can get the education from me and the treatment. But when they go for the annual physicals, they're not getting the care. So that's concerning. So let's look at some other things in terms of structural racism or institutional racism in medicine. Algorithms in healthcare. You've probably heard more and more about that. I remember October of 2019 was the first study that I heard about where they determined that there's somebody built into the algorithm of an emergency room. They were using this software, and if everything was equal, um, the factor that would determine whether or not you were admitted or discharged was whether or not you were black or white. So that decision tree sent all blacks home and all whites into the hospital if they had the same symptom profile. Or look at New Orleans during COVID. They're disproportionately sending black people home to die of COVID because they don't have the beds, but the numbers are different for white people. In terms of renal disease, Dorothy Roberts was a Robert Woods Johnson scholar. She's a professor at University of Pennsylvania. And while as a scholar, she wanted to understand where the factors regarding renal function tests for blacks and whites being different. And that was just the focus of her project. And what she determined, it was something called Ipsy Dixit, because I said so. You have the medical pompous professor who believes the stereotypes he tells the medical school students and his colleagues, and it just perpetuates. So in other words, there's no evidence base to support these renal function disparities. And that means that blacks are more likely to be more ill when they're referred for renal function because the numbers are worse. So they come in and start to get treatment at a more severe state of disease, which also contributes to the prognosis. And we know it's worse than for whites. But it's also that if you have that worst stage of disease and you're a candidate for renal transplant, you're going to have more physiological damage that may render you ineligible for that. So it's a discriminatory practice in that way too. So Professor Roberts actually has gone on a crusade. There are TED Talks, her Twitter, she goes around the country, et cetera, with this. And she's had some traction. Beth Israel Hospital, that's the Mass General, and several other hospitals have signed on. And it's growing because I believe in September, UCSF also signed on to this. And it's controversial because people are in their comfort zone, but there's no evidence base for it. So we're encouraged to continue to look at that, and hopefully it'll become standard at some point. Some hospitals say we do a correction for that algorithm. Well, that's not sufficient, especially for me. I talked with someone and told them, I stopped prescribing lithium when I was in New Orleans for 7 years. Why? Because it's so hot there. The precarious fluid balance can lead to fatalities. Then once I started to read Dr. Roberts' work, Professor Roberts' work, and see that there was no evidence base, I started to question what was I doing? And I don't use it as a first line in most cases because of this, and African Americans, because I know that over time, and you see the people who practice and prescribing lithium for decades and decades, they will tell you that there are going to be changes in renal function if a person's on it long enough. Pulmonary disease is another one. Cystic fibrosis, we're told that that is a disease of white people. Well, there are blacks who get cystic fibrosis. It's just less common. In my career, I've had 4 African Americans who have had cystic fibrosis on my caseload. The studies show, and their personal experiences pan out, that it takes 4 years longer to diagnose a black person with cystic fibrosis than it does a white person. Why? Because people use the appearance or the race to bias things. A 6-year-old black kid comes in with pneumonia for the 3rd time in 3 years. A 7-year-old kid comes with pneumonia. He's here again. He's here again. But when you put that X-ray up there and nobody's looking at the name of demographics, a resident medical student, radiologist, ER doc goes and says, "Wait, who's the kid in the ER with cystic fibrosis?" When you remove all those parameters, but it also applies to kids. There was a study at UPenn in the early 2000s that showed with child abuse, they took the same long bone fractures and X-rays and they changed the narrative, and the doctors were more likely to diagnose black child abuse with, if it said black male, inner city, black child, than it was middle class white child, etc. Because the doctors identified more with the white child, which is bad for white kids because they're not getting picked up and getting treated and getting the services that they need for child abuse. Meanwhile, black kids overall disproportionately are being diagnosed, labeled victims of abuse. And I'm not saying that they shouldn't if they're being abused, but that begs the question. Okay, so in terms of perception of pain, there's a National Academy of Sciences study that showed that medical students and to some degree residents believe that the perception of pain is lower in blacks than whites. So whites are, or the tolerance for pain is higher than blacks than it is in white. So whites are more likely to get pain medication, which may be why whites were more likely to die or get sucked up in the opioid crisis. It's happening to blacks in greater numbers now, but they were not getting the meds, which means that blacks unnecessarily were suffering from pain. And there recently was a study about kids going into the hospital for appendectomies. And even in that case, they gave black kids less medication, pain medication, than they gave white kids. So it's there. The data is there. It's irrefutable. In Cleveland, they did a study and found out that minorities were more like black and brown people were more likely to die of motor vehicle accident fatalities. Again, where you live, the fact that you may not have resources to drive means that you're in the zone of danger when you're walking down the street. In schizophrenia, we're going to talk about a little bit more, and we're going to talk about resident burnout and racism. But before we do that, I'm just going to briefly mention a recent hypertension study in Black men. I don't have the reference here because it just jumped into my head a couple of hours ago to remember this. They did a study in California with recruiting Black men from barbershops to have participate in hypertension screening and related screening. And what they found was, in terms of follow-up and compliance, Black docs had an increased adherence to follow-up and treatment. And the remarks in these statements were different about how they were perceived. So that was the patient's perception. He really cared about me. He had a great sense of humor. I felt important. And that's not to say that it wasn't the case with many white docs, but statistically significant fact was that it was more often with Black docs. So what they did was they just looked at the charts and saw what the difference was. And one of the differences was that Black docs were more likely to personalize the note and put more personal information in it. A great sense of humor, hard to engage, needs housing, etc. Where white docs were more likely to sterilize that note, as we're taught in medical school. Now, when I did my internship in pediatrics, one of the things I learned was that we always ask people about kids, about their pets. It's a great way to engage kids, but I still use that with adults. And there are patients who say, you know what, I think I need a little different treatment, etc. But thank you. You always asked about my parents and you always asked about my dog. That meant the world to me. So that's another way to engage people. And Hallmark said a few years ago, the number one growing card, the most rapidly growing card segment they had was sympathy cards for pets. Pets are important to people. It can be a way by which you engage people. Of course, there are other ways too, sports, whatever, but getting them there is a nice way to break the ice. And if that means that they feel more comfortable and they can establish relationships and be more compliant, then it might be worth it. And there are efficient ways of doing this. One of the things I've changed in my assessment is not in the medical school books, but one of the first things I ask before I ask about any other history of depression, etc., is I ask about traumas, losses, and stressors. And I put that at the top of my note because it's so important to understanding a timeline and how people are functioning. And it helps me fill in the spots and the gaps. What's important to you? Not your neighbor, not your father, not your boss, but what do you perceive as significant traumas, losses, and stressors? So, what about psychiatry? Well, one week in August, I looked at JAMA Weekly for everyone, because I get everyone, dermatology to cardiology, etc. And here are the studies about systemic and implicit bias I found. The NIMH had a study that involved 10,000 subjects, and what they determined was that increased exposure to outdoor artificial light at night is associated with decreased sleep duration and increased likelihood of mood disorder in adolescents. There also are small studies that said that the decreased sleep duration can be associated with an increased risk of suicide behavior. And we know that in Black kids, the number of suicide attempts and completed suicides is increasing exponentially. Now, it's a relatively small number, so you have to take exponentially in context, but it's growing at a rate faster than it is with white youth of a similar age. Well, if you think about inner city communities, you might live on a courtyard, or you have the lights. You may not have the curtains or uh, shade lights or anything, or things to block out the lights. So you might be overly exposed relative to someone else in a suburban area where they don't have as many lights. So that can be a contributing factor. Um, in terms of the Finland cohort birth study, they looked at 14,000 people, and they found that maternal antenatal corticosteroid treatment is associated with increased risk for preterm birth and increased mental and behavioral disorders in children. And some of you, we talk about infant mortality. I remember late last year, there was a devastating situation where a chief resident, I believe in the Midwest, died in childbirth. Just devastating. So infant mortality in people of color is a huge concern, especially in um, inner city and more congested communities. And we're still trying to look at and find out what's going on. But if you are in an inner city and you look at the environment, you're likely to be in the less desirable community with increased risk of air pollution, etc., and increased risk of global warming. And so basically, climate change is affecting that. It can affect your breathing. Asthma is at higher rates there. And that means that you're more likely as a mother to require corticosteroid treatment for that and potentially other problems. Then there was a study, and this one is remarkable because they used 49,000 consecutive refugees who were placed in disadvantaged neighborhoods in Denmark. Basically, you come up, where's a spot? Boom, where's a spot? So basically, they just placed you, and then they went back, and depending on the neighborhood you were placed in, the more disadvantaged the neighborhood was, the more likely you were to have an increased risk of cardiovascular disease. So it's just like we say in this country, your zip code determines your longevity. Now, this is an article ad from Archive of General Psychiatry, and I learned about this ad initially from Jonathan Metzl and Dorothy Roberts' article, Cultural Racism Meets Cultural Competence, which was a 2014 article in JAMA Ethics. And basically, when you look at this ad, it was a 1974 ad selling haloperidol, brand name Haldol, marketing it for schizophrenia. And you see the terms assaultive and belligerent there, and you see a Black man. Well, those kinds of images, just like um, that the military family, but found that she was associating guns with negatives and things, negative associations with Black people, and didn't know why. This has a subliminal message that angry Black people are more likely to have schizophrenia if they're angry and belligerent. Well, studies from this point forward repeatedly have shown that if a white person goes to an ER with a certain symptom profile and a Black person has that same symptom profile, the Black person is more likely to be labeled with schizophrenia and get treated with antipsychotics, whereas the white person is more likely to get diagnosed with affective disorder. Then Metzl did, in his book How Schizophrenia Became a Black Disease in 2009, he did a study, showed a study that he did with journal articles. And he looked at the journal articles in which the race was mentioned versus those where it wasn't. So the test articles are the ones that where you knew that the population had Black people in it, and the random articles did not. And you can see a clear difference between these articles on schizophrenia research, where if Black was mentioned, you have a higher rate of anxiety, hostility, a little bit less withdrawn, more paranoid, more aggressive, and more violent. So the adjectives that are used in research studies are associated with the race of the person. So there's clear bias here. So Let's look at this study because this is important for you to understand. This is the Association of Racial Bias and Burnout among Resident Physicians. This was a cohort study, and they looked at the Maslow burnout inventory, which just asked 2 questions about burnout, and then they did the implicit bias, these card sort of words. Some of you may have done the implicit bias study where they show you pictures and you have to associate. For example, I did one with Donald Trump and Bill Clinton, and they are just putting their pictures there, and you have to say if they start with Donald Trump good or Donald Trump bad, Bill Clinton good, and you have to match the words, and they're timing you, and then they switch it around and say Donald Trump good, Bill Clinton bad, and then they see what your reaction times were. Now there are flaws and problems with the test, but it also shows you how you react to things in terms of time. The explicit bias test, they used 100 points feeling scale, and they only surveyed non-Black second-year resident physicians. Good half of them were male, and most of them were younger than 30 years old. And what they determined was that stress levels were directly related to implicit and explicit bias against Black people. In other words, depending on how stressed you were more likely to be cruel and insensitive to Black patients. So that can help you understand why some people don't return to healthcare settings and how they're treated. Or we saw Susan, I can't remember her last name, may she rest in peace, but the physician who put it on YouTube about how she was being treated in the hospital and recently passed away. So there is that bias in many cases. Okay, and then in the third year, when you have less stress, the bias goes down. The explicit overt bias goes down, but the implicit bias, just like the state senator who had the comments about Black people and hand washing in COVID, is still there. So that doesn't wash away. So I wanted to show you this one quickly. Justice involved patients testifying by Black, because you're going to see patients involved in the justice system. This was a Philadelphia study done in 2018, 2019, and what they did was they recorded people who spoke African American English, 8 of them native speakers, and they read a passage, and they had court transcriptioners or court reporters transcribe it. Well, the sentences had 59% accuracy, and the words were 82.9% accurate. And who, what, where, and when were often transcribed correctly. Sentences were correctly paraphrased only 1/3 of the time, and that was not related to accuracy. So that shows an implication of training for court reporters, but you can see where that can lead to somebody being found guilty or not guilty. And what the court reporters agree is that they need more training, and they also say they're told that they should actually ask questions about when they don't understand, but it's highly discouraged. So this speaks to the problem. Now, what they're trained on to get their 95% accuracy to be certified would be on recordings by court reporters, judges, and lawyers. So right now they're trying to reproduce that study with Latinx individuals, native Spanish speakers. So what about the APA? We have this initiative that involves advancing the integration of psychiatry, supporting research, and supporting and increasing diversity within the APA, as well as education. And what we determined was we were not doing as well with supporting and increasing diversity within APA, serving the needs of evolving, diverse, underrepresented, and underserved patient populations, and working to end disparities in healthcare. Now, to be sure, we have the Black Men in Psychiatry pipeline, which recruits promising college-age students who are interested in psychiatry, gets them mentors, brings them to meetings, et cetera, and that's being diversified to Native American, Asian Americans, et cetera. So we're doing some things, but we weren't doing enough. So before even the George Floyd and the other tragedies that happened, and when people lost their lives unjustifiably, we were already working on doing something. However, when those things occurred, that expanded the charge. So what the APA has done since June was, let's look at the Board of Trustees. They announced an issue of concerns about COVID and health disparities in late April or early May. They announced a statement that denounced racism, denounced police brutality. And in July, the Board of Trustees had a roundtable discussion for between 1 and 2 hours where every board member talked about their perceptions about race, where they'd like to see the organization going, and their thoughts, so that we could see, each of us would know where the other is. And then they also realized that from something, an article that someone wrote, that in retrospect, the APA has never had a definition for minority and underrepresented. The APA Assembly, which is like its Congress did, but not the organization. So there's a work group that's working on that. And as the definitions are evolving, that's been challenging. And we also hired retained consultants for APA Board of Trustees, and we're retaining one for the headquarters to look at what we can do better as a board to improve member relations, especially as it relates to minorities and underrepresented people, but also all members. One of the things that was a big issue was that we had not had a director of diversity and health equity in over a year. But everything we're doing as a board is consistent with what AAMC and corporate America is doing. So then there was a structural racism task force, and I was selected to be chair. There are 10 members, and here they are. Half of them are board members, and half of them are subject matter experts. Not all board members are white, and not all subject matter experts are Black. For example, the top middle is Renee Bender. She's a past president of APA who's into correctional psychiatry, and she actually bought the board to San Quentin prison so that they could tour it and see. So she brought the prison into the boardroom, or the boardroom into the prison, which is something that was never ever done before. So she is a subject matter expert on correctional psychiatry. Now, there's some tension about whether or not you want board members involved in a task force of this nature. And I had to make sense of this before the meeting started. Why would I want board members? And I thought this was a brilliant idea. Why? Because board members know other board members, and they know how the board process goes. So in terms of the data that we develop and such, they can present that, and they know, and the board feels comfortable with its own to accept and ask questions, etc. And we did not want our findings to be shelved. So that's really important. And we've done pretty well. We've gotten 15 out of 16 recommendations approved, and the 16th was shelved. And it'll come up again in March because we needed some more data. So the mission of the task force is providing education and resources for some APAs and psychiatry's history regarding structural racism. And there's been an 9-article series from Jeff Geller, who's a historian, a history buff, and a president of APA about this. Our founder, Benjamin Rush, owned slaves and said that Blacks suffered from a disease called laziness known as negritude. So we actually have a work group looking on the history and how we're going to handle that. And then explaining the current impact of structural racism on the mental health of our patients and colleagues, developing actionable, achievable recommendations that we don't want to sit on the shelf. So we have to give reports. We've given 2 reports. The next one, 3 reports. The next one is due in March, and that'll be the annual report. And we have to do quality assurance. Whenever you're doing these types of projects, you have to go back to your charge and make sure you're meeting criteria. And the decision was made that while other minority groups want to be involved in this process, the first year would be dedicated to anti-Black racism. Now, that benefits other races too. It's just that the subject matter experts were all subject matter experts on Blacks and psychiatry. We don't do this alone. APA is putting a ton of resources. We've got all these staff to help us. If I appoint a work group, we get a team to work on it, and they get us our data. They help us coordinate things, and it would be impossible to do while you're practicing full-time otherwise. So we're grateful to them for that investment. The goals are, for me, it's collaborative. We want allies, not adversaries. And I constantly say, if you go and say, this is racist, you're a racist, you're not going to achieve anything, because again, some of this is unconscious. And if you tell a person who's not aware of it, you attack them that way, they're not going to want to collaborate with you. But you also have to look at how you're interfacing with them, because you may be contributing to the problem. So we have to be strategic and thoughtful and step back. What's going on with me? Just like my friends in the museum, what's going on that's contributing to this problem? What can I do differently? And it takes a village. So we have it member driven. We get member surveys and such. They're not scientific, but if you're on Facebook or Twitter, we do post them there periodically. We've done, I think, 3 or if not 4 of them already. I think we've done 3. And it's transparent. So we put the results on the website. If you go to the psych.org, you'll see at the top right-hand corner, Structural Racism Task Force. We have readings and other resources there. We have town halls, and we want to minimize excluding people. So these are our work groups, definitions, resources, communities. We're also looking at what other psychiatry organizations are doing and trying to bring that together and their programs. We have the Board of Trustees work group looking on how the board functions, et cetera, how board members are elected, et cetera. And that one was just presented in December. Components, a work group, etc. Clearinghouse Town Hall. We have the town hall meetings that you're free to attend. And we're also looking at resident and fellow issues. Now, the thing about this is we're looking within APA, not because we wanted to, but because members said that it was most important to them. So in other words, it's not us. I put out surveys there. What do you think we should deal with? And the numbers kept coming back. We got to deal with APA before we have to look in our own backyard before we can look elsewhere. So with that said, in terms of allyship, and I'm going to finish here, remember, if you see something wrong, say something, be accountable to yourself about how you're coming across people, because you may have an ally there, somebody wants to work and help you, but if you keep offending them and such, there's no connection there. And using your skill set to improve the situation. And also, don't forget the invisible backpack and resources, especially when you're interviewing patients. If you have any questions or concerns you'd like to send to us, please send it to taskforce@psych.org. We do answer all questions, and I appreciate your time.
Thank you so much, Dr. Wills. It was such a wonderful presentation. Do you have time for some questions?
Sure.
Right. Feel free to write a question in the chat box or just unmute yourself and ask.
Let me find the chat box here. Let's see, got
Don't be shy, everyone.
I guess I'll ask the first question. Thank you, Dr. Willis, first of all. I was wondering how I guess this affects kind of your specific population of pediatric, in like pediatric psychology as opposed to like general psychology.
Well, I see adults and children. I'll tell you how it's affecting adults because it delves into children. One of the things I found since COVID is that more people are bringing their kids onto the screen to ask me about COVID, to ask me about racism or community violence, etc., because the parents don't know how to address that. So in response to that, I collaborated with the APA Council on Children and Their Families and asked them, they were interested in contributing something to structural racism, and they actually produced a document called How to Talk with Patients and Their Family About Racism. Well, as a child psychiatrist, I got where they're coming from, but I said, listen, we got over 38,400 members, and most of them are adult psychiatrists, so we have to actually include their concerns too. So it goes from childhood to geriatrics. So that's available on the web page too. It gives a lot of case examples about what's going on in dynamics and how you approach and evolve it. So, and also in terms of children, the other thing is the remote schooling. Not everybody can learn the same. The domestic violence rates are up. I've had parents say, I'm sorry, Dr. Wills, I've got to stop my appointment because the teacher wants me on Zoom. He's acting out again. We've seen all kinds of responses. In addition, one of the things kids worry about, if mom goes to the grocery store, will she get COVID? Why are people shooting people? I'm having nightmares about it. Or their anger is up, or they're acting out more because they see this. So right now, the big thing is it's not just Black kids, because they're all seeing this. They're seeing, what happened this past week. If you saw that on television, which I refused to turn it on, I was actually with a patient, and she kept looking back and said, is everything okay? She said, you don't know what's going on out there? And that's how I found out. And I made sure I didn't turn on the radio or the television. I talked with a couple of friends and said, well, I'll worry about it in the morning. Why? Because I didn't want to get caught up in that version of reality TV. It was scripted reality TV. and you don't want that. But also in terms of where their next plate is coming from, their next meal is coming up. That's a huge issue in inner city communities, but even more so given the pandemic and people losing their jobs and such. So our department actually did a food donation drive for the food bank. I usually give the food bank, so I had already donated, but they collected a substantial amount of money to help out. It's affecting everybody in all sorts of ways. Autistic kids, that's a particular one. I've had more, and between April and June, you had frequent reports of autistic kids with autism, I should say, or autistic disorder. I'm running away. And I had a couple of my patients that did it. I asked one of them, what made you decide to leave? And he said, I wanted to see people. His schooling was cut. He was a senior. He was preparing for graduation. And he has mild intellectual disability, formerly known as mental retardation. And he just didn't understand it. He wanted his cap. He wanted his gown. He was used to seeing people. He didn't get to see his teacher. He can't flex that way. Another kid I know would not leave the house. She was scared to death of COVID. She's gotten better. And one of the things, her mother's a healthcare professional and worked with COVID. So mom was going into COVID, and there were times when mom had potential exposure. She just couldn't handle it. So you have the whole spectrum of behaviors. Some kids are loving it because mom or dad are home, or they can watch TV, or a lot of them aren't doing their schoolwork, etc. One study showed that the decline in Ohio test scores is not what they expected. What they didn't show was 25% of the people did not test. And those are the ones who are going to have a lower test score. So you're, again, looking at data, you already know that it's important.
Thank you.
I put that resource that Dr. Wills was referencing in the chat box for anyone who's interested.
I can't see the chat box on my side. Are there any other questions?
Anybody?
Hi, Dr. Wills. Thank you so much
Hello.
for your presentation. My name's Ismara. I'm actually a psychiatry resident at Michigan State.
Nice to meet you.
Nice to meet you. And so I kind of had a question about, like, coming from a resident standpoint, what are some grassroots efforts that we as residents can do to kind of help reduce the systemic racism, or what kind of efforts can we do, like, while we're in residency?
Well, that's a great question. I got asked that, especially around George Floyd, and I got that question from residents and young attendings. And what I told them is, you can feel free to protest, but it's not a wasted investment for you emotionally, but it's a wasted investment for relatively wasted investment for structural racism and dealing with health disparities. And I said, you know what? If you see one additional patient per week, at the end of that, you will have seen, say, let's say 45 week a year. You will have seen 45 additional patients. That's going to put a dent in health disparities. So that's 1 week. So if you have 52 residents do that, that's one full-time, or attendings, that's one full-time equivalent of psychiatry that is addressing the problem. So in other words, it's important for you to protest if that's important to you, but you are blessed with a gift and some really expensive, high quality training. And there are people out there desperate for that. So that's one way to do it. The other thing is, when you have issues with patients, find somebody, people not who are going to tell you what you want to hear, but to tell you the truth and help you work through it. The more you work through as a resident, the easier it's going to be when you are out there putting out your own shingle. Because patients, they're not going to be easy. And I see it with adult residents, child psychiatry residents who start with child often have problems. and working with children. Why? Because they haven't learned the bedrock of adult psychiatry. And child psychiatry is all about parents. If you can't get them to buy in or foster parents in the system, you can't treat the child. So talk when you're having issues, don't go to the people who are going to say, yeah, you're right. Go to the supervisor or the mentor or the colleague who's going to help you be more introspective about it. And that'll save you time down the line. So we do, our residents do NAMI walks, we do food drives and other activities. I had residents rotating with me at the Juvenile Justice Center trying to understand that process. And if you're going to work with challenging populations, it's better to do that earlier in your career, and particularly better to do electives when you're getting quality supervision. Pick supervisors who are going to help you grow, not those who are going to be your friend.
Thank you so much.
Sure.
I have a question. We talked a lot about just how kind of the medical side of things, there's a lot of obviously structural racism that's just very deeply embedded. But we also see these unconscious and sometimes very consciously explicit biases from our patients. How do you deal with patients like that, especially, being in psychiatry?
Well, that's a great question because it's not easy. People are going to come in with their attitudes, etc. Some of that may be related to structural racism, but some people are just downright nasty. Just like some races are just pervasively nasty, some people who are Black or brown are nasty, and they alienate everybody. And that's going to be. The bottom line is, one of the things I tell Paige, if you have had quality supervision and know your stuff, if you're trying harder than the patient is, it's time to step back. And that's where you get good supervision. What's going on here? Why do I feel a need to try and she's not? It may be that you're missing a diagnosis. It may be just, that it's a personality issue. I fired patients before. I don't want to tell you how many have gotten angry with me because I won't write emotional support animal letters for them to get on the plane. That slowed down with COVID, but basically I follow the law, and people, they think that your doc is supposed to do what you want to do. And often, disproportionately, the people who want those letters are the ones who don't show up for appointments. But if I say I have documentation that you stabilize on medication, therefore you're free to bring your animal, but I can't say it's medically necessary because it was never part of our treatment plan. Some people accept it and some don't. I've had to fire a couple who came and screamed at me. The key is that no matter what happens, you have a right to be safe. And if you're not feeling comfortable or you're feeling abused, that's when you get someone in there. And residents, just like Black people, need allies. I heard a story about a resident who was in the South, and she had a white patient who didn't want to be treated by a Black person. And he said all kinds of nasty names, etc. She went to the chief resident. They wouldn't do anything. And eventually, this happened 3 or 4 times, and he was screaming so loud they had to, so they took care of the case. And then they failed her on a rotation. She doesn't know how to get along with people. That's absolutely unacceptable. She lacks clinical skills. The point is, you're in residency to learn how to deal with this. And the proper response would have been to bring the resident back in and say, listen, we have all types of people who are going to treat. She is qualified as anyone else. If you like to be more selective, you're free to go elsewhere. So in other words, your chief residents, your supervisors should have your back. And if they aren't, that's where you're talking with the other residents to find which ones will not only just have your back, but make sure you get the education and training that you need.
Well said, thank you. I just got a private message of a question too. Someone asking that you had mentioned town halls and how to get involved with those and where to find out more information.
Okay, go to psychiatry.org. That's the APA webpage. Look at the top upper right-hand corner, and you will see on the top half of the page, you'll see Structural Racism Task Force Web Hub. We've got another one coming up in February. I just got the flyer. I can email it to you, Marissa, and you can share it with your colleagues.
That would be great.
I
Thank you.
just got it this morning at 6 a.m. So we'll get that to you. Okay.
Perfect.
But yeah, so this one actually, yeah, this one will be up your alley. The work group decided they were going to do residency training. So they have some training directors. I think there's 4, and then they're going to have some residents asking questions and such. And we'll also get a task force update from Dr. Reed, who's our APA trustee at large and a member of the task force. So yeah, that'll be February, I think second week in February. And the other ones are available. You can stream, I think, the second and third ones on the web too. The last one was particularly good because we had an early career psychiatrist, someone who's Latinx, talking about how the experiences that his grandmother had resulted in the family not learning English, not speaking Spanish, because she was penalized in this country so many times. We had an Asian woman, and we had an African American woman, and I think that was all. But they all gave different perspectives, and that was a really nice one, and getting you to think, and it was really well received. But I will email you that link as soon as we're done.
Great. Thank you. And I'll make sure I send that out.
I've also posted, it's also going to be posted on LinkedIn and Facebook. I'm on Facebook, or I'm on Twitter at CWills4APABOT. So you can follow that. And
thank you. And we just got another question sent to me. And says, I would like to ask if Dr. Wills can talk more about diversity within the Black community. For example, the work of the sociologist from the University of Michigan that you mentioned in one of your slides, and how that might become relevant for us as psychiatrists in the course of our residency training.
That's an excellent question. I think back to one of my supervisors who told us the hardest person to treat is going to be the one who looks like you. Why? Because of the transference. They're going to make assumptions that they're going to take you for granted and then assume that you have their experiences and you know where they're coming from. And you likewise have to make sure that they don't do this. So I'll tell patients, I told one yesterday, I said, I want to hear it from your perspective. Don't assume that I understand anything. Tell me just like you tell anybody else who had no clue, because I really want to understand it from your perspective, not the next person's or not my last patient's or my neighbor's, but from your perspective. So that's the first thing, make no assumptions. And people will think, I've had patients call me, hey girl, you knew I wasn't going to take that medicine, so why don't you just call me and we can talk on the phone? Well, there's some assumptions there that first of all, I'm not going to respond to that patient. I'll have the staff call that patient to set up an appointment. And if they come in, we can talk about it, but I'm not going to invest. I tell patients I'll meet them halfway if they're trying. But if they're not trying, then I need to focus on the people who really are trying, because there's but one of me and so many patients and a wait list. So in terms of that, in terms of communities and community mental health, that can be a burnout job if you don't do it right. You have to know where you end and the process begins. For example, I see patients, I see attorneys, I see all sorts of people who have come in because they're depressed and overwhelmed because they're working with an inner city community. But I'll just give you an example I'm a Hurricane Katrina survivor, so we're not focusing on a patient, just my observations when we moved to the military base in San Antonio. There was a Black mother of 3, and she had a CDL, and she drove a limousine. She was working 3 or 4 jobs, which is not unusual for poor people in New Orleans. And we went to San Antonio, and the bus driver told her about a job. And then he came back. It was a long route. She went to the place, and when she got back on the bus, because again, it was a long route, so by then she was finished, she grabbed him out of the seat and hugged him and was crying. Not only did she get a job, but it paid 45% more than she was making in New Orleans. It was a day job. It was a school bus driver. And the way they did it there was she just drives the bus and they have a staff person telling her which route to take. So she could just focus on driving in safety. Not only that, but they enrolled her kids in school the same day. There was another guy there who was given some opportunities and applications to fill out, etc. And they asked him, well, how's it going? Do you need some help with this application? No, I'm not going to worry about that. Y'all just need to give me some money. So those two people were in the same situation, lost their homes, flooded, had nothing to go for, but the response was very different. So they went halfway with both of those, but which one are you going to help get some new shoes for that first day of work? You're going to focus on the one who's trying. Not that you don't want to be disrespectful to the one who's not trying, but you have so many resources. But you also have case managers, et cetera, to work with you. But if you spend your time, and I found jobs for patients or made suggestions about things. I don't have any food. Well, the food bank is over there. I've got a list for them. You need a ride to it? No, I'd rather sleep. So what's going on? Maybe it's psychosis, or maybe it's just how this person wants to live, or they keep complaining about not having a job and they don't really want one. So over time in therapy, you work on those things. That's why you have supervisors, group supervision, et cetera, to discuss these things and get a feel for it. Else you're going to burn out, but you should not be treated poorly. Everybody has a different story, but there's also the situation where that story may be so embedded in so much trauma and other circumstances that you may not be able to get to it in a rapid manner. Here's an example. 2 kids commit a homicide, both African American teens. One of them is very remorseful about it, feels bad. He did it to protect himself because the guy said he would kill him because the brother sold him false drugs. He felt awful about it. He confessed. He went to the police and turned himself in. The other guy, he got arrested. He got caught. He killed his grandmother. He was hardened, would not talk to anybody, was unreachable, so they just left him there. Okay, a year goes by, a new resident comes in and meets with him and says, you know, you had a rough time here, blah, 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 and connects with him at the right way at the right time. And that kid broke down and cried. It turned out that that kid had been a victim of serial sexual abuse, had PTSD, depression, psychosis. Grandma had repeatedly let him be abused by her boyfriends, etc., and selling him out. So he snapped. But he got tried as an adult and sent to the adult system. And by the time they didn't do the proper evaluation, they didn't know the psychological testing, etc. But he was the more damaged kid. And what you'll find in juvenile justice is that kids who are bound over to the adult system are more likely to have psychosis. They don't all have it, but disproportionately, they are more likely. It's statistically significant. So you have to look at those things. But I've had patients also, I've treated them for 2 years, PTSD, etc. And one of the nice things about working in a prison is that you get to see the patients. They're a captive audience. They're not going anywhere. So you really get to learn medicine. So it was something I did earlier in my career. Anyway, after 2 years of treating this woman, we finally get her stable. Every session, I'd ask her about nightmares and flashbacks. And this was like, wow, she looks fantastic. She feels fantastic. And I said, okay, I'll check in with you in a month. She said, wait a minute, aren't you going to ask me about nightmares and flashbacks? And this was the one time in 2 years that I had not asked her. I said, well, I've asked you all those other times. And she said, well, maybe I'm ready to answer. I am having them. I said, well, help me understand. Why is it different this time? What? She said, well, maybe I'm feeling well enough to realize I've had them all along. I was too depressed to realize I was having it. So again, tolerance, patience, you're not going to push them, but you work through it. You never know. This is layers of illness, layers of trauma. And she had some serious traumas. There's no question. But, you know, and the psychotic person who says, yeah, I've been I thank you for never giving up on me, even though I did horrible things. So you'll hear some of that too.
We have another question in the chat
Sure.
box. The student says, thank you for your time. Your talk was very informative. Do you have any book recommendations that you feel have been particularly moving and insightful?
In what area?
I'm assuming regarding structural racism or just racism in medicine or anything related to your talk. Or just
Okay,
books.
that's a great question. The ones I gave, the ones I mentioned were all studies I did research on. If you want to understand structural racism, look up Metzel and Roberts. Metzel, Roberts, JAMA, structural racism, and it'll pop up. So that's the JAMA ethics article from 2014. In terms of resources and such, you go to the structural racism task force page. It is psych.org, and then you look at the top right and click on that. There are tons of resources there of all sorts. They even have a Sesame Street video where they discuss racism with kids there. So we are compiling things. If you have any suggestions, just send it to psych.org. We will review them, etc. It takes a village, and we want every perspective that we can get because none of us have all the answers. But yeah, there are lots of resources there. There's some, we're looking for more videos also. There are also some good videos on structural racism. If you look at Peggy McIntyre, she's got some videos on Vimeo about the invisible knapsack and how she talks about the fact that she wasn't aware of the privilege she had relative to her colleagues who were Black, and she was getting the grants because she had connections and didn't even realize she had them that her colleagues were not getting. So there's so many angles by which you can go with this. The other things you can look at are if you go in structural racism in medicine, there are a bunch of articles about all different fields, et cetera. I've researched some of that. There's a nice series of articles in the New York England editorials in New England Journal of Medicine about how to diversify medicine, why I'm leaving, what needs to be done better. A lot of those are on at the web hub, in the web hub. But if you found something that's not there and you think it would be great, let us know.
Great. So it looks like we're out of time. If anyone has a dire question, feel free to ask it. We can probably fit one more in.
Or yeah, or you can do task force, TASKFORCE at psych.org, and we do respond to the questions.
Great. Anything?
But it's been a pleasure, and I wish you all the best in your careers and your future.
Thanks so much, Dr. Wells. It was an honor to have you here.
Keep up the good work, future doctors.
Thanks. All right, thanks everyone for being here. I will send out a link to the recording so you can share it, as well as the contact information to get in contact with Dr. Wells. Have a good night, everyone.